Great. I think we'll get started because we have quite a packed agenda and quite a lot of interesting presentations for today. So again, good morning, good afternoon, good evening, everybody, for everybody just kind of joining in. It is my pleasure today to be kicking off and starting the webinar launch to introduce the Child Wellbeing Matters global dissemination study of the findings, but also to introduce the practitioner tools. We apologize in advance, but there won't be any translations for today's webinar, but Pedro has just popped in the chat that you can turn on your caption for translation, so you're able to do so. In addition, just to say that in a couple of days, hopefully we will be having research briefs translated in different languages, and that will hopefully be shared on the Alliance website that we will be launching. Just another few housekeeping. You may have noticed that the chat for today will be blocked. We are hoping that for any questions that you may have, please feel free to pop them in the question Q&A chat. Although we won't be answering the questions today by the end of the webinar, we will be collecting, IRC will be collecting all the list of questions, and then hopefully we'll be able to share back some of the answers once we share the link to the webinar, including the research brief and all the tools and resources. Because we have so much to cover, and without further ado, I would like to please hand over to Ina from IRC to kick us off for the welcome.
Thank you very much, Susan. I don't know if you can hear me all. Yes? Thank you, and good morning, good afternoon, and good evening to everyone. It's a pleasure to be here with all of you. It's also impossible to speak today to such a crowd of practitioners working on child protection and humanitarian work without addressing the current context we're in and the challenge that the humanitarian and development sector is facing, which might be one of the largest we've faced yet, with the drastic and unprecedented defunding of both life-saving and life-affirming programs. A lot will have to change about the way we work, but what doesn't change is that this work is still needed, that this work is still respected by those we serve, and this work is still critical to the lifelong outcomes that we want to see in the communities we serve and in our world at large. We are all committed to ending violence against children, and that's why we've convened here today amidst the challenge and the heavy cloud of funding cuts. Despite all of that, we still need to not stop to organize. We need to continue persevering and to think about how we can use and leverage data and evidence to do the most good we can where it matters the most. So I'd like to thank you again for joining us to hear particularly on the data and evidence we have, and we've been working together on surfacing, interpreting, and sharing on child well-being. The phrase child well-being is a very common terminology, not only in our sector, but in our lives, right? A lot of us have been children, live around children, serve children, and raise children. There have been attempts to define what it means from the perspective of practitioners, but also from children themselves. There is still no one single perfect answer. What could well-being mean for children fleeing conflict, for a child on the move, for a child who's been experiencing violence at home, in the school, or elsewhere? Researchers on this call will give you the definitions we use in this study so that we can better all share a common framing and understanding on how we're going about this data and this evidence. To me, more importantly, the question is not so much what does cover child well-being, but really how do we improve it from a child perspective, and how do we understand and give meaning to the experience of well-being by a child. I think about the children living in emerging and protracted situations or in crisis within crisis, like the ones we are unfortunately seeing unfold and being perpetuated in countries like the Democratic Republic of Congo, Sudan, Gaza, or El Salvador. How do we, as practitioners and in collaboration with duty bearers, continue to work to contribute to a child well-being in such an environment? And how can we sustain that well-being despite all the challenges that children around us are going through? The protection sector has professionalized this aspect of social work through various existing minimum standards and tools, yet we still need to focus on answering this question. What are the components of these tools that truly contribute in the most efficient, in the most impactful manner to child well-being? At the International Rescue Committee, we prioritize research alongside program implementation and in collaboration with all of the practitioners in our sector to measure quality and ensure we promote evidence-based practice as informed as possible by contextual realities. We also try to make sure we are as efficient as possible in low resource environment to make sure that we optimize available resources, but that we also recognize when we need to tailor work with others in partnership to cover needs. We should do what has the most promise to make a difference in the life of each child, and this commitment to evidence-based practice is the founding motivation for this study, which you will hear more about today. I will not preempt the results because there's a lot coming on and a lot of sharing and a lot of richness to what will be shared. We will hear from our lead researcher and other partners on the study and what these results say about children, their well-being, about the way we work and the way we need to carry forward. However, I'd like to ask you as you listen to interrogate yourself if you have given caseworkers, case management, and social work in crisis priority they deserve, regardless of the type of context you work in, whether they're protracted, whether they're conflict affected, whether climate-induced disasters. I would like you to interrogate your practice, to interrogate the tools we are using, and to see how this research can bring value and added perspectives to the work you're doing. I do hope that at the end of these events, you will be convinced not only that we must address adverse childhood experiences and secure better childhoods for the children we serve, but also that you will be convinced that there's a need to continue working on specific aspects of social work and case management brought about by the research as critical assets and pathways to solutions for children and to make childhoods better, safer, and more nurturing. If you have more questions, then we are keen to hear from you, and we are keen to continue collaborating with you on how to continuing investing in interrupting the cycle of violence in a way that is not only financial, but that is also steeped in shared knowledge, shared experience, shared framing of issues and challenges, but also shared evidence and data. I would like to finish by recognizing that we couldn't do this without the partnership and collaboration of many. So I'd like to first thank our research partner, the Universidad de los Andes in Colombia, for leading this work and for sharing this journey with us. We are grateful to the child protection team, children and parents involved in informing this study. And lastly, I would like to extend my thanks to the case management task force members of the Alliance for working with us over the past 3 years. Thank you very much all. Looking forward to hearing all about the results, the thinking and the reflections emerging from this research. Welcome again to all of you, and over to you, moderator. Thank you.
Thanks, Inia, for that wonderful introduction and welcome. I'll now hand over to Cosmas. Go ahead.
Yes, thank you very much. Yes, good morning, good afternoon, everyone. And thank you for joining us for this very important dissemination session. My name is Cosmas Ayala. I serve as the Deputy Director for Programs with the International Rescue Committee in South Sudan, based in Juba. As a new nation, South Sudan continues to face an intensifying humanitarian crisis driven by ongoing conflict, climate shocks, food insecurity, mass displacement, disease outbreaks, and economic decline. These challenges have significantly increased the demand for humanitarian assistance, with children bearing the heaviest of the burden. Through the Humanitarian Needs and Response Plan 2025, estimates that approximately 3 million children urgently need child protection services within the country. Many of these children face severe risks, including abduction, recruitment into armed forces, family separation, abuse, neglect, exploitation, and violence. Their situation worsened by the influx of returnees that are coming through from the Sudan crisis into South Sudan that is causing more suffering for the children. Today, as we gather here to discuss the findings of the Child Wellbeing Matters, improving case management practice through research, the study done in Colombia, in Nigeria, and of course, we're starting that in South Sudan. I'm pleased to announce that the IRC South Sudan has also launched the same study within our context. For the past 3 decades, IRC in South Sudan has been implementing child protection case management as a critical response to children's needs. For children experiencing family separation, neglect, abuse, violence, and exploitation within the country. This work has been carried out in collaboration with the Child Protection Area of Responsibility and the Ministry of Gender, Child and Social Welfare within the country of South Sudan. With this study, we aim to deepen our understanding of case management and exploring how children and caregivers define quality case management, the experiences of case workers and their approaches to child protection, the key components and ways that they contribute to child well-being, and ultimately whether case management is an effective and cost-effective intervention for child protection. By gathering this evidence, we seek to strengthen advocacy, fundraising efforts, and demonstrating to donors that case management truly makes a difference in children's lives. The IRC in South Sudan remains committed to strengthening and leveraging insights from the Colombia and Nigeria work, and for all of us in this field for advancing our research and using these findings to enhance the quality and impact of child protection interventions within the country and everywhere else. I look forward to the discussions today and the valuable knowledge that will be shared that all of us will consume. Thank you very much, and I look forward to further discussion. Thank you.
Thank you very much, Cosmos. Now, before we get into the meat of the research findings, we would like to share a small video that basically presents a snapshot of the findings and a video that could be used to share the results back with communities, with children and caregivers that took part as part of this research finding, but also widely across the sector. So Pedro, over to you to share the video, please.
We've seen this project work so well. It's made a difference, you can tell. The case workers there to show the way. They gave support and hope each day. More confidence and feeling secure. Taking care of themselves, more for sure. Starting their own thing feels easy now. They're stepping up and learning how. It's clear to see well-being's on the rise. Emotional distress is fading from their lives. Basic needs, give them a hand. Helping teenagers thrive and take a stand. With their caregivers, bonds are tight. Let's fighting now, things feel right. They're pitching in with tasks at home, making good choices as they learn and grow. Their emotions are in check each day, for self-esteem on full display.
Great, thank you very much. So the video is also available in Spanish, and I think this is such a great way. It's such a great video, so fun to share the findings from the results, and we hopefully will be able to share those as well after the webinar. Now I would like to introduce Maria Cecilia, the lead researcher on this piece, to take us and as we deep dive through the findings of the global study. Maria, over to you.
Thank you, Susan. Let me share my slides. All right. So you can, I'm guessing you can see my screen now, right? Yes?
Yes.
Great. So hi everyone, good morning, good afternoon, wherever you are. My name is Maria Cecilia. I was a PI for this research study on improving case management practice through evidence, really. And so a little bit of history of this project, which I found, very, very exciting to be part of, as in collaboration with the IRC and colleagues in Colombia and in Nigeria, the local offices of the IRC, we were tasked with a very, very relevant and interesting project where we had to start from scratch in a way, because the idea of this project was to understand how the mechanisms by which case management influences well-being, child well-being. And as Inha was saying before, there are various understandings of what child well-being means, right? There are different definitions of that. And also, as you all know, case management is a highly individualized and tailored intervention that doesn't really follow a standard session by session process, but instead really responds to each children's needs. So there were at least two big challenges to begin with. One was to kind of like produce a conceptual framework that would capture a case management, what happens in that process as an intervention in a standardized way, right? And second, how do we define well-being and how do we assess what happens after the intervention in terms of well-being? So first, a big step, the big milestone in this project was to produce this conceptual framework and link these different aspects of what happens during case management to our definition of well-being. So if we think about case management, the research team thought that there would seem to be three big domains of this intervention. So one has to do with the response, right? So this is defined by the services and referrals that children get when they are accepted as participants. Second, the relationships. This is what I often refer to, the magic that happens between the children and the caseworkers. And finally, the implementation, how this intervention is implemented in terms of whether the children preferences are prioritized, if there is a smooth transition intra and inter-institutions in terms of collaboration, coordination, and referrals. So big message to begin with, three big domains: response, implementation, and relationships. And then a big question as well was, how do we define well-being? And we decided to have two different definitions. So first, we can define well-being as safety, basic needs, relationships, and agency. So if these four indicators improve, we can say that children are better, the child well-being is improved. And also this part was very important to us as well. How do we link this definition of child well-being to broader discussions in the literature on mental health? So we decided that we would define well-being as mental health in the positive, right? Emotional well-being, and also we would measure child well-being in the negative, in terms of a likelihood of depressive symptoms. We had a longitudinal study where we took measures at 3 points in time: at baseline, before case management started, after at midline, between 6 to 8 weeks after implementation has started, and by endline, so end of case management implementation. We had initially planned for a follow-up, which didn't happen in the end because of climate-related issues and timing, floods in Nigeria, and I'm sure you all know how the work on the ground transcurs in humanitarian contexts. So we started with 90 young people, adolescents in Colombia, and 99 adolescents in Nigeria. We retained most of them throughout the study, and we implemented quantitative surveys measuring all the outcomes I just mentioned in terms of well-being, and also complemented that approach with qualitative interviews with children and caseworkers and also with caregivers. And this was done with the aim of capturing not only how well-being would change throughout the process, but also capturing how children themselves and parents themselves saw and define well-being. So we from the start we wanted to combine quantitative and qualitative methods. So a quick breakout of our participants, almost 15 years of age as an average. Gender was roughly evenly distributed. In Colombia, we had Venezuelan migrants, young people from Colombia, and young people with dual nationalities as it often happens at the border. This study was conducted in Cúcuta, which is at the border between Venezuela and Colombia. And then in Nigeria, the large majority of participants were from Nigeria, 3% from Chad, and this study was conducted in the Maiduguri region in northern Nigeria. The large majority of participants were internally displaced in Colombia, and a third of them were so in Nigeria. Almost half of the kids were not attending school, which was a big important outcome in these descriptive statistics. And also, well, most of them had a home where to live, but there was a variety in terms of housing arrangements. The large majority of cases in Colombia were categorized as in need of psychosocial interventions. Almost half of the sample in Nigeria was deemed to be a case of neglect. In terms of results, so remember I described that we would work with a first definition of intermediary outcomes of well-being defined as safety, basic needs, relationships, and agency. What we saw in our study at Endline is that we see an increase in each of these indicators after a case management. This meaning that better young people feel more safe. They feel that that their basic needs are being met or met in a larger more met. Their relationships are improving, and their sense of agency is also improving. Everything, although this obviously we cannot, because of our design, we cannot say this was caused by the intervention. We can definitely say that we see a correlation throughout time. So kids who, young people who participate or receive case management at Endline show improvements in these outcomes, in their well-being generally defined. And when we see these results by country, we see that all intermediary outcomes improve for Colombia specifically and for Nigeria specifically. And in Nigeria, compared to Colombia, we see that the effect of relationships decreases and the effect of agency increases significantly. In terms of what this means qualitatively from the adolescents' perspectives, they describe feeling an enhanced physical and environmental safety. They talk about safer school environments, less bullying, less violence. In terms of agency, they describe enhanced self-confidence and independence, less fear, greater involvement with household tasks. And also, they describe the development of emotional and decision-making skills, which, as you will see in a minute, becomes a big component of what case management does. So one of them, for instance, in Colombia, a male adolescent says, because my caseworker talked to me and told me that I needed, I need to help my mom because she does everything on her own, and that's what I have changed. So we see adolescents getting more involved in tasks and chores at home, helping parents, helping siblings, and a much more closer relationships with their immediate environment. In terms of basic needs, young people describe access to food and basic needs that are alleviate stress. Obviously, this remains not enough, right, in terms of basic needs. And also, this was very important to them as well. The livelihood support for caregivers fostered financial independence among young people. They are also, through these small grants, they are able to take care of themselves and have basic needs like soap, detergent, clothes, shoes, etc. In terms of relationships, adolescents describe improved family relationships after case management, healthier communication, better conflict resolution, and also significant improvement in peer and community relationships. And these will become very, very important in the mechanism at work where case management improves well-being. Quick look at this. So you may remember that I mentioned at the very beginning that we were measuring these intermediary outcomes, basic needs, agency, safety, and relationships, and how they connect to mental health, defining the positive and the negative. What we saw here qualitatively is that these intermediary outcomes are related amongst themselves. So a change in the sense of safety improves relationships, and basic needs can also help improve relationships. So these are all intertwined. A quick example of this. Many adolescents refer to a sense of safety as a sense of safety at home because, for instance, there were many conflicts with their parents, with their siblings. So because they felt more secure at home, they were able to feel more better relationships and more a heightened sense of agency. That in turn helped them make important decisions and reinforcing bonds with the family and the community. Another example, when adolescents feel empowered to make decisions, it improves their relationships with their parents and community members, which in turn can influence how adolescents manage basic needs, such as resources for their families. So as you may see, these intermediary outcomes are interrelated in how they ultimately lead to better mental health outcomes. Something very important was also the role of case managers. We focused on that and explored a little bit more what happens between the case manager and the participant. And what we saw is that case managers provide emotion management tools. For instance, conscious breathing, emotional expression through art. They also foster open communication between children and caregivers. They are instrumental in improving the relationships that young people have with their families. They provide these fundamental tools that allow them to function better in high stress, highly vulnerable contexts. So things like emotional regulation, interpersonal skills, coping strategies at school become very important. And this is something that is very important to say, is that this is not to say that the solution to these high stress, highly vulnerable contexts is teaching young people to manage the context, but that's not the only solution. But acquiring these social emotional skills allow young people to navigate better these challenging contexts. This, of course, needs to be coupled with interventions that change the the context where these young people are growing up. In terms of the primary outcomes, this is mental health, defining the positive and defining the negative, right? And what we see is that at endline, young people exhibit higher emotional well-being and lesser likelihood of depressive symptoms. And these changes are significant between baseline and endline. When we see this by country, we see that case management has a positive effect on well-being for Colombia and for Nigeria, and that the effect is slightly stronger in Nigeria compared to Colombia. When we look at depressive symptoms or mental health defined in the negative, we see that case management significantly reduces depressive symptoms in both countries, and that the reduction in depressive symptoms is smaller, slightly smaller in Nigeria compared to Colombia, although both remain significant. In terms, then again, doing the same exercise, how young people define mental health and mental distress, how they feel this qualitatively. Young people in Colombia describe oftentimes family time, so the quality time they can spend with their parents and their siblings, how they perform at school, and also community engagement. This is textbook definition of a layer understanding of context where obviously young people will feel better if they fare better in this key context, meaning family, school, and community. In Nigeria, very, very similar definitions with adolescents stressing family support and community security. In terms of mental distress, how is this defined by young people? Young adolescents in Colombia describe family conflicts, financial constraints, and physical injuries, not being able to play or spend time with friends. In Nigeria, family conflict, then again, is cited as a main source of mental distress or what it means to feel emotionally distressed. Financial hardship, as in Colombia, and in Nigeria in particular, also distress related to climate, because they faced floodings towards the end of the study. So flooding and housing issues were also described as sources of mental distress. A quick overview, we wanted also to, in terms of mechanisms, understand whether the number of sessions and duration of case management was related in any way to the outcomes. And we find that for Colombia, we did a case study for Colombia. We didn't find any significant effects for the number of sessions or duration of case management in child well-being. But we saw, and this was measured with the survey, I don't have time to show you like the nitty-gritty, but bear with me here. Empathy is related. So this is a big, important piece of what happens. Empathy shows a significant positive correlation with well-being, also with self-efficacy, safety, relationships, and agency. So the level of empathy that adolescents feel from their caseworker is a very big and important aspect of all of this. I'm gonna skip through this to just focus on the relationships aspect. So as I said, the quality of the relationship between the caseworker and the participant, the young person, is a very important component of how case management gets to improve well-being. And in this sense, young people underscore the importance of feeling that this relationship is confidential and that they can trust their caseworker, that the caseworker practices active listening and is really engaged in what is happening. In Nigeria, there were many discussions and references to the importance of an intervention that is culturally sensitive, that respects priorities, worldviews, and is inclusive. And in both countries, adolescents were very emphatic in how they benefited from this non-judgmental support, where the caseworker is there for them and is working to improve their well-being through a trust and confidential relationships. In terms of some challenges that we face and some facilitators we identified in this study, young people cited often low family commitments in terms of how they felt like they were attending and going to the case management sessions, and sometimes family, parents, caregivers were not as engaged as they were. And in terms of the connections with outside institutions, this discussion that I was starting earlier about how case management can successfully kind of like provide a psychosocial tools or psychosocial skills, this doesn't necessarily translate to services around and systemic changes in the context. So in Colombia, we saw, for instance, limited services for migrants and oftentimes re-victimization by institutions where young people or their families try to connect with these new services and they don't get what they need. In Nigeria, we saw, as I said, flooding and logistical difficulties and institutional delays in funding and funding gaps, as we all know is happening now with the sector. Facilitators identified were collaborative networks. So in both countries, caseworkers were very emphatic about the importance of the connections they can have with other institutions in the context and how that facilitates the referral processes, and the importance of having flexible action plans and proactive follow-ups. Very quick view at the recommendations for the humanitarian sector. In terms of the recommendation by adolescents, they mentioned entertainment in waiting areas, better scheduling, or more flexible schedules for the sessions. They wanted more longer or more frequent sessions, which I think it's a good sign of how useful they find this all to be, and increased community awareness. So basically, their insight was try to intervene at the community level as well. Caseworkers are also recommendation in terms of self-care spaces. It's very important because the emotional work they do is very, very deep and can be complicated to manage at some point. Manageable caseloads, assistance for admin tasks, which take time, increased funding for individual assistance, and reestablishing institutional offerings, which it's a main challenge they were facing at the time of this evaluation. And last slide, we had, so in terms of some learnings we had from the research process, we had an attrition rate that was somewhat expected, but was still high. Caseworker turnover, and in terms of how often caseworkers changed jobs or moved away. Issues with the unpredictability of the context, and some important learnings in terms of engaging children in research. As I said, a main aim of this study was to understand their perspective, and we created a community advisory board. We sat down with them to revise the interview guides, the surveys. It was a very collaborative and participatory approach. The video you saw at the beginning of the presentation was a way for us to, that was actually intended to share the results with them. So we thought of this adolescent-friendly way of communicating research. And something that was very positive as well was the fact that we trained IRC staff, so case managers, to collect this data. So that was another important learning of this process, because it makes the research process much more feasible in this context. And just as a final thank you to the teams in Nigeria and Colombia, without whom obviously this project would have not been possible. That's it for me. Thank you so much.
Thank you so much, Maria, for that very informative presentation and really taking us through the findings and sharing the importance of the work that everybody here on the call does, and really showing and depicting the impact that caseworkers, case managers, and teams have on children's well-being. Hopefully everybody will be able to deep dive a lot more once the research brief is shared, and the research findings will be shared on the Alliance site as well. Just mindful of time, so I'll hand over to Claire and Elsa, the child protection consultants who work on the practitioner tools that were informed by the research findings and the study that was just presented by Maria. So Claire and Elsa, over to you, and Pedro, if you can just pop the presentation up for them. Thank you very much.
Thank you, Suzanne. Yeah, so as mentioned, this toolkit has been developed based on the very insightful research Maria presented, as well as a desk review and key informant interviews. And the toolkit is specifically designed to support practitioners to measure well-being and child satisfaction as part of ongoing program monitoring and evaluation. And next slide, please. And the toolkit links to 2 sets of indicators within the child protection minimum standards, and which are part of the forthcoming child protection case management task forces monitoring and evaluation framework. We'll look more closely at these in relation to each tool as we go. Next slide, please. So now we'll delve a bit further into the tools. I'll start by going through the set of wellbeing tools, and then my colleague Ilse will talk through the satisfaction tools. So just to begin, these tools are aligned to the Alliance definition of child wellbeing in child protection in humanitarian context. The definition is a holistic one, covering a lot of the topics which Maria also discussed, including safety, basic needs, connection and care provided by caregivers, supportive relationships in the community, and children's opportunity to exercise agency. And the overall purpose of these tools is to assess whether children's well-being has improved during the case management process, and what the contribution of case management is to this change or not. They've also been designed to identify necessary actions and program adjustments that might be required, and they're designed in a way to empower and involve children in this process. So going back to those indicators that were on one of the earlier slides, the indicators directly relevant to these tools are the indicators in the child protection minimum standards, which look at the reported increase in children's well-being addressed through the case management process. The indicators are the same, except that one is from children's perspective on this, and the second looks at their caregiver's perspective. So based on this, we've developed one version of the tool for children and one for caregivers. And in terms of who implements the tools and when and how, the tools are designed to be implemented by caseworkers themselves, because they have that pre-existing relationship for children to feel comfortable and safe, and because they go into several areas of the child's life where sensitive topics could come up as part of the discussion, depending on what children choose to share. And so caseworkers are trained appropriately for this and can also act on any issues raised as part of the case management process. And in terms of when they should be implemented, in order to be able to report on those indicators, it is required as a minimum that at end line, around the time of case closure or shortly afterwards, the tools would be implemented. But it's also, where possible, it's recommended them to implement them at the beginning of the case management process as well, so that we have that comparison between baseline and end line. So as I mentioned, we have two tools. There's tool 1A, which is called the Wellbeing Wheel and is for children aged 6 to 18. And then we have tool 1B, which is the parent or caregiver version, which is very similar, but just adapted to parents and caregivers. And we've developed different scales so that the first tool can be adapted both for the younger age group within that as well as older children. And for children aged 0 to 5, we have the caregiver tool, although this can also be used with the older children. So just to show you some of the ways in which the tools are adaptable both to different contexts and also to different ages, stages, or needs of the individual child or caregiver. We have these different scales. So the 3-point scale is good, okay, bad. Then there's also a 5-point scale, very good, good, okay, bad, very bad. Designed based on children's developmental stage, along with different ways that these can be represented in a child-friendly way, and also either visually or physically through stones or pebbles and that kind of thing, in cases where a tactile, more physical option is more appropriate. And these can also be selected based on the context and what is appropriate in the context as well. Okay, so in terms of what the wellbeing tools look like in practice, they're implemented through a session with a child or caregiver through 4 key steps. And in the toolkit, there's guidance and prompts to support the caseworker through each of these steps. So it's starting with introducing the session, and then conducting the activity. And you can see here, we've put on the right-hand side, you can see an example of what the wellbeing wheel looks like. And this is used either in a printed format or drawn in the ground or other formats to basically show the different wellbeing domains and then work through defining those with the child and giving them the opportunity to define what it means to them. And then to step back and for them to look at their overall well-being and the contribution of case management. And you can see this one in this example, it's got the 5-point scale with the emojis representing the different responses. And then we also have guidance on closing the session and any follow-up actions required. And we have guidance and templates for documentation and next steps, including how the findings can be analysed and also, importantly, how they can be actioned. Now over to my colleague Ilse, who will share the satisfaction guidance and tools. Thank you.
Thank you, Claire. So indeed, we have one part of the tools to measure or assess an improvement in well-being, and then the other tool that we developed jointly is a child and caregiver satisfaction tool. Pedro, I will do the slides if it's fine for you. Sorry to just like quickly put this out there. So for those who know, like in the past, we had in the case management forms, we had a satisfaction form, let's say like this, but in our experience when using it, it was quite lengthy and it wasn't always that easy to adapt, for example, to younger children. So we tried to make something easy and practical. And so the overall purpose of the tool is to measure the percentage of children within a caseworker's or within a child protection agency caseload that express satisfaction with the services and support they received throughout child protection case management. So we try to break it down in few objectives. And first of all, we want to calculate satisfaction. So determine a percentage of children who and caregivers who are satisfied with the services they receive. So we had to make it quantifiable, and for example, to be able to come to a result is like, for example, this number or this percentage of children are satisfied and this number or percentage of children are not. But just to have the number would of course not be sufficient, because we also want to understand, okay, what made you happy or satisfied with the support that you received and what didn't. So we also have to have a qualitative component where children or caregivers can explain why and give a bit more background. And then also this information needs to be used to, for example, future inform programming. So we also wanted to enable the possibility to identify possible trends. For example, if there's an area where there's a high level of dissatisfaction, that you could say, okay, we take this on board and we try to see why or how. When we were looking at satisfaction, we try to understand, okay, it's not just one question like, are you satisfied or are you happy? But actually we have to look more into, okay, what does create satisfaction for a child and a caregiver? And we indeed also used the research results, which led to what, for example, Maria said before, empathy being the magic, or the relationship with the caseworker being key. And this makes sense because it is indeed, do you feel supported by your caseworker, which reflects on the relationship. So we took this on board when drafting a tool. And then when we try to break down, okay, what makes a person, for example, satisfied, or what contributes positively to the relationship that the caseworker has with the child and the caregiver, we also came, we bumped into the guiding principles as mentioned in the Interagency Child Protection Case Management Guidelines. I will show you the tool in a bit, but just for you to know that this is the background behind it. So we are using this tool to report against two indicators, the percentage of children who report satisfaction, and also the percentage of caregivers who report satisfaction with the child protection case management services they and their child received. And then when we look at, okay, who should implement the tools, it would not be possible if the same caseworker does the satisfaction assessment, because it will not be very objective and reliable. So in the guidance is explained that it's recommended to have another caseworker implement the assessment to ensure objectivity and reliability. And then when we think when it should be done, it is required to do it at the time of closure, preferably within 3 months. If we wait longer, I think it will be too far back in the mind of the child. And it is optional at midpoint as well, to inform ongoing improvements. And then when we look at which cases, for the satisfaction assessment, it is recommended, it's actually required to do it for all cases that are closed. However, we need to be mindful that in specific circumstances, for example, large scale and rapid onset responses, emergencies, it will not always be possible to do this for all cases, and then a representative sample can be used. When we look, for example, at which cases, we recommend to only start with the child itself after the age of 5. So starting from 6, and before that, similar as with the child wellbeing tool, it can be done with the caregiver. And then quickly, I would like to present how to implement the session. So the full guidance is included in the document, so I won't explain the full guidance. It will be shared, the full document with the tools, with the guidance through the Alliance website in the coming days. But there's a steps in the session in which, first of all, it's very important that the session is introduced, and that, for example, the child and the caregiver are made feel comfortable, that they understand the purpose of discussing, for example, their satisfaction, that they feel comfortable knowing that their information will be confidential, and to make clear that they have a to make sure that they have a clear understanding of what this session will entail before starting. And then to conduct the activity, we started with determining a set of 8 statements in which children can respond. Again, same as with the tool that Claire presented, the answering options are fully adaptable. We gave guidance on it. For example, for younger children, we recommend a 3-point scale. For older children, 5-point scale. Which scale you want to use, stars, traffic light, smileys, it's up to the caseworker to determine. And then to start with explaining the statements. For example, your caseworker does what is best for you, and then the child can say, yes, I'm happy about it, or not, this is good, okay, bad, or very good, very bad. And to go over these different statements. For example, the caseworker helps you when you need, the caseworker makes you feel good about who you are, the caseworker helps you make choices about your life. And then also we have one more, which is, since case management started, has it made changes in your life? No, for example, everything feels more or less the same. Or yes, case management has made changes in my life. And then to look at, are they positive, are they negative? So the focus in the statements and in the activity is mainly on the relationship with the caseworker, and then one question, one statement about the changes that it made. And as with the child well-being tool, it is important to also always close the session properly, thank them, and on a positive note, and then have also documentation of the answers provided to ensure accountability and to be able to identify trends. And also, which is my last point, is that when, for example, the child scores 0 on any type of statement, this indicates like a serious dissatisfaction against some significant issue, and this should then always be flagged immediately so that follow-up actions can be taken on, for example, the individual or program levels. And so we're coming to an end of this presentation. So we have 2 tools, one to measure child well-being, one to measure child satisfaction. They are completely adaptable to the different contexts, to the child's age and abilities, and guidance will be provided. On top of that, there are also a few visual tools that you can use to, for example, facilitate these sessions with younger children. So they will be shared soon, and I hope that you will be happy when you see the result. That's it. Thank you.
Thank you so much, Elsa and Claire, for this great work, and yet another important practitioner tool and resource for case management teams across. So thank you very much for your work on this, and hopefully, yes, we'll be able to share this soon and discuss next steps for dissemination and socialization of the tools. I would now like we will have a group of panelists who will share just briefly thoughts, reflections on the research studies, on the practitioner tools, and importance of looking at evidence through research when it comes to child well-being and case management. So first, I would like to please introduce Karen to introduce herself and just give her reflection on the research study. And yeah, go ahead, Karen.
Brilliant. Thank you very much. And thanks for inviting me to be part of this panel. It's really exciting to hear these results. So my name is Karen de Vries. I'm a professor of social epidemiology at the London School of Hygiene and Tropical Medicine in the UK. And so my area of expertise is around violence prevention. And I've worked both on violence against women and also violence against children. And I lead a group here now called the Child Protection Research Group. So we're focused on various different aspects of child protection research. So yes, very, very glad and very excited to hear these results coming out. And I really want to congratulate all of you. And Maria Cecilia, I think this is a really amazing study. So well done. And I imagine that a lot of the conditions and contextual challenges around the data collection were quite significant. So it just makes the results all the more impressive. So I guess my main reflections are, I think this is quite an important piece of research because it's about this case management process. And there's very little, from what I can see, more academic empirical research that's actually been conducted about this process, despite the fact that this is a kind of main mechanism we have in our toolbox of prevention and response to do around violence and to address children's needs in complex settings. So I think it's really important. And what I particularly liked about how you were framing things and discussing things was paying attention to both the kind of structural and contextual factors alongside children's individual agency, and kind of recognizing the sort of boundaries and interactions and limitations that these structures can place on individual children, whilst also recognizing that, you know, these interventions we can do can still help and support in some ways. I was curious to hear, also being a person who does lots of research on school-related violence, about some of the outcomes that came out around safety and a safe environment in some of the intermediary outcomes. And some of those outcomes sounded to me like children talking about being physically safer and having a safer school environment. Those sounded like slightly more structural outcomes to me, which I thought was really interesting, given what I understand these case management interventions to mainly be, which is more individualized. So I'd be very curious to hear more about that, probably outside of this webinar. So I quite like that. I guess the big questions on my mind as an academic researcher and one who produces evidence that we can use to kind of advocate for more funding to enable us to do these interventions, I guess is around this question that you brought up about how we can attribute causes and causation. So I think it's clear that through the study, you were able to follow this sample who'd been in the case management process over time and see changes in some of their symptoms, which is great. But as you rightly point out, we can't necessarily, because of the study design, attribute that to being in the case management process. And linked to that, I think the case management and similar intensive interventions like this, which are quite tailored, are always going to be very expensive, which, especially in the current kind of funding environment, is something that we're going to need to, as child protection practitioners, increasingly be able to kind of argue our case for why do we want to use this intervention, especially when they're so costly. So I guess in terms of future directions, this is where I'm thinking our next steps are as a group of researchers who are interested in this, is how do we demonstrate the effectiveness of case management compared to other cheaper interventions, and how do we get a good handle on the costs and benefits of doing this. Okay, but overall, massive congratulations. Over.
Thanks, Karen, for these very insightful reflections, and very much in line with our thoughts and thinking also within the case management task force and how we want to move forward in terms of building that evidence. So thank you for that very insightful reflection. I'll now hand over to Brendan Ross, who is the head of UNICEF Child Protection South Sudan. Go ahead, Brendan, over to you.
Hi. Yeah, thanks, Camilla, and thanks for the research. It really, I've got a few reflections. I think first and foremost, it's great to see that there is this research happening, and it's great to see that people are trying to build an evidence base that we can use to advocate for funding, because this is obviously the elephant in the room when it comes to research like this. And I think, you know, bearing down on that point, one of the things that we're trying to look at a little bit is something that was touched on in the research, and I was hoping it could go a bit deeper, but it wasn't enough time really. But it's around dosage, you know, how much time, and I do I did see that you said it didn't seem to matter how much time, but obviously it does, because you need a relationship, and you need to be able to establish that relationship and that trust with the child, and it's great to see. I really picked up those 2 points around empathy and relationships, which was something we're really banging on hard about here in South Sudan. It's imperative that the caseworkers build trust and build relationships and have a degree of empathy with the children, and if they're able to get improved well-being and strong outcomes for the child. So that's one thing that I'd like to hear more about, really, because when it comes to working for UNICEF, we're always talking about scale, and we have to talk about scale. We're about building child protection systems. We're about building a workforce, and this question around how many cases and these questions are impossible to answer, but what we can answer is well, it's essential that a relationship is there. It's essential that empathy is there, and that is going to have well-being, and so then we can start to build a workforce around that. Because when it comes to our child protection emergencies programming in particular, what we tend to do is really bad practice. We throw 6 months worth of funding at a partner organization. They hire new caseworkers. They may not even be from the area, and then we expect them to be able to go in and do good casework, which is just asking too much. It's asking too much of the children to trust those people, and it's asking too much of the caseworkers to build that trust in that time frame with no likelihood of it being extended. So these are some of the questions that would be good to sort of go around. The next one, on scalability, I think we've got a real problem, and this isn't probably very helpful for this group, but we've got a real problem where there's too many tools. We're looking at a workforce in South Sudan, and I think many countries across sub-Saharan Africa, where the workforce is not particularly well educated. They're not degree qualified social workers, if they're qualified social workers at all. And so we're delivering tool after tool after tool and guideline after guideline after guideline without great ways for them to be able to filter through and find the best ones, or find the most appropriate ones, or to contextualize them. And so these are some of the challenges we've got here. And I think this is where we're starting to look at other ways, and the casework supervision and the hiring of the caseworkers. How do we find the right people? So there's lots of questions there that sort of are on and above, but to say, frankly, I really like the tool. My fear is that there is some data management in there. There is a guideline in there, and how does that get in the way of the relationship? And that's the key focus and the key finding that I thought we found there. And so the methodology of implementation, the how in terms of using the tool is going to be interesting, but really great. And I love the endeavor to try and show that casework works. We all intuitively know it works. We see the results of the children on the ground, and it's a difficult program to sell, because the numbers are so low, but these efforts contribute to that, and I'm super grateful, and we'll certainly look forward to receiving the tool, and look forward to seeing how we can start to play with it and introduce it and use the findings. Thanks very much, everybody involved.
Thanks, Brandon, for those reflections and for bringing that practical perspective in terms of the day-to-day struggles and the challenges, right, that our teams face on the ground, and really taking up these tools, but also the importance of the research finding, and how hopefully that will be impacting and addressing good practices for colleagues as well. Elsa, I wanted to introduce Elsa from ECHO, who will also be sharing her reflections for today. Elsa, over to you.
Yes, no, thank you very much. And yes, indeed, I'm working for ECHO. I'm based in the Amman Regional Office, so covering the MENA region. And my background is child protection. I've been a child protection specialist, as we would say, for quite a long time. And the research is just preaching a converted person already, actually. So I'm not maybe the right donors to talk to, because I already acknowledge how essential the role of the caseworker is and how essential is case management, if there's anything to actually promote and advocate for as a child protection intervention. And I know that this is, I really understand how complicated it is to get funding when it comes to case management, and the caseworkers is resource intensive. It costs a lot, and unfortunately, it's not really the most visible work that is being done. So let's hope that with this tool, it will help to actually make it more visible. One thing is that as ECHO, we've been always, we continue and we will continue since, there's many points that Brendan actually already said. I feel like he stole them from me. So just to say, maybe from a donor perspective, as ECHO, we've been always investing in case management. It's even, I'm not sure if I'm supposed to share that, but even internally, we do have a lot of trouble sometimes to make our colleagues understand, who are not necessarily protection expert and even less child protection expert, how critical it is, not only for child well-being, but to be honest, the angle that we are taking, and maybe that's something that I've been missing in the research, is how do we actually how does it contribute to mitigate protection risk and to reduce or remove, in the best case scenario, the protection risk? So not only from the child well-being angle, but basically bringing, and that's only, recommendation for your advocacy with other donors, is to also really show how that actually contribute to remove the protection risk. And I think linked to it, what does it take to do a good case management so that it's actually effective? So maybe in the research, if there could be beyond the satisfactory survey, if there could be some other way to actually measure the quality of case management, the quality of the action of the case workers. I think that's something that donors find quite important as well, because we do see a lot of intervention, but that are difficult to actually measure in terms of impact. So yes, child well-being is important to demonstrate, but again, there are also a number of other aspects that could be taken on as well to again improve the advocacy and make it a bit more stronger. One thing I've been thinking, and maybe it's linked to what Brendan discussed earlier, is what the research is highlighting, the critical role of the caseworker is a bit, this role might be a bit difficult for caseworker to carry out in situation of displacement, of emergency. You mentioned and you alluded to children on the move, migrant children, displacement, etc. But I feel that this is not tackled enough in that research, because honestly, what we've seen is it's very difficult to keep a caseworker on a long run. Not only for structural issue, there are a lot of turnover, but also because in emergency situation like we see in Gaza now, they simply need to also at some point, they're unable to actually follow up as long as it would be required. They need to go back to their family, or they need to go back to their house. There is a high mobility. So I think it would be interesting to have a bit more variety of context, emergency context, protracted context, because the tools and a bit like with what Brendan said also in terms of education, you do not have the same capacity to start with, depending on the region, depending on the country where you're working. So that's something that needs to be looked at in terms of capacity building, coaching. And maybe the last one of the last element beyond the stability of the caseworker, how do we work around that actually? Might be linked to the system. There's a lot of work that has been done in terms of and research when it comes to the social workforce within the national system. How does it complement the work of caseworkers that we might have trained on a more ad hoc basis when the national system is too weak or not functional? How do we actually make sure that those two can complement one another? So again, and that means basically that humanitarian donors like us, of course, we won't be able to work on the system strengthening. I mean, we can include it a bit, but it's not enough. Our funding cycle is super short. So we need also to make sure that we do have development actors, development donors around the table from the very onset. I know that UNICEF is doing that already, and that's something that is being looked at more and more within the Nexus. But practically speaking, and that's also our role as donors, to make sure that we do actually engage with other financial instruments within the EU who have a longer term perspective, and other development donors where sometimes we won't be able to actually ensure a continuum of care for those children. So if you take reintegration, we could, for instance, engage in reintegration as a humanitarian donor, but it would be only for a year or two. And sometimes this is actually something that needs to be done. I mean, it will take 4 or 5 years to achieve a good protection outcome and a good child well-being outcome. So see, these are the reflections that that basically that research inspired, yeah, triggered basically. But thanks a lot for that, and hopefully yeah, we'll I'll be curious to hear more.
Thank you so much, Elsa, and thank you to all the panelists for sharing your reflection. And these are definitely reflections that we will be taking back. At least myself as a co-lead of the Case Management Task Force, I think you all raised some very valid points and things that we have been thinking about within the Case Management Task Force in terms of next steps and priorities. So thank you all for all these reflections and for sharing your thoughts and for being open and practical as well. This brings us to the end of our webinar, but before that, I would like to hand over to Camilla Jones from the Alliance to just close us off for this very interesting and insightful webinar. Over to you, Camilla.
Thanks so much, Suzanne. It's a real pleasure to be able to provide closing remarks at this webinar. It's a really important piece of research, really important project, and I think that's only emphasised by the panelists who've just spoken, with so much food for thought around how we resource this area of work. So yeah, I just wanted to reiterate the thanks that Ina gave at the start of the webinar to all those who've contributed to this critical project, from the Alliance Case Management Task Force, but also the partners and staff of IRC and the Universidad de los Andes who've led the project. It's really incredible that we've come such a long way as a sector, that we're now able to measure tangible outcomes from this key intervention area. And it's crucial that we're able to deliver our case management work according to quality standards, so that we can avoid doing harm and so that we can ensure return on our investments. Let's face it, I think some of the speakers have already outlined this very clearly, that case management isn't a low investment area. Even just getting case management right, as Brendan and Elsa were saying, is tough. But then when you add on additional services for children at heightened risk, like unaccompanied and separated children, or MHPSS services for survivors of GBV or CAFAG, they become even more sophisticated as an intervention. The Child Protection Minimum Standards outline a clear framework for quality and accountable case management. And our newly revised case management guidelines give us a sort of step-by-step guidance on how to achieve quality and outcomes, such as caseworker to child ratios, supervisor to caseworker ratios, competencies of staff, and of course the quite complex tools to secure children's data protection and confidentiality. But many of these tools have been developed just by practitioners like us coming together and sharing what we think works, and we've worked out what it is and we've documented it. But now this really enables us to see if it is working in practical terms and to hear that directly from the children and the caregivers, so that we know if we're actually achieving quality through these frameworks that we have. So it's really crucial that we receive this feedback in these resource-constrained times. So many agencies are having to ask themselves, how do we adapt if we really have to, and being prompted to streamline. So we want to really know that if we're making those difficult decisions, that they're informed by evidence and directly the feedback from the children and the caregivers. So my sincere hope is that implementing agencies, partners and donors in this area invest in this crucial accountability mechanisms, whether that's replicating the research in other contexts, as Elsa said, or actually advocating for funds to, include an M&E and accountability element in our child protection projects so that we can implement these tools. But also taking action to close the feedback loop. We need to hear from the children and the caregivers, but also tell them what we're doing in response to their feedback. And then, of course, sharing this learning amongst the sister agencies within the Alliance and beyond, so that even if an agency hasn't got the resources to use these tools, they can still hear how we're adapting our approaches and our guidance in response to it. So as Suzanne said, the Case Management Task Force is really hoping to continue this stream of work in terms of data and evidence, and also to look at what kind of accessible advocacy notes we could put together to encourage investment in quality case management. It's really hard to make the case for ratios, and we're often put under real pressure to deliver more with less. So we hope that this research will help us to make that investment case. I just wanted to flag that there are a number of ways you can continue to engage with the Case Management Task Force and the Alliance, and I'll put these in the chat. We have a number of different social media platforms depending on your preference. We also have a community of practice which you can sort of join. There's about 300 child protection practitioners on that community of practice, which we run in collaboration with the Global Child Protection Area of Responsibility. We also have a newsletter that you can subscribe to through the website. And of course, the Case Management Task Force page is rich with resources. We've done a lot over the years in the task force, and I've put the email address there in case you want to send a direct query to Suzanne, which she can then respond to in consultation with the membership. So yeah, many thanks for everyone's contributions, and wishing everyone a wonderful rest of your day. Thanks so much, Suzanne. I don't know if you want to say any closing comments as we have a few minutes left, but
thank you very much, Camilla, for that. I think we'll end for there, and I'm sure we'll be in touch with everybody here with the tools and the resources. And yeah, in terms of next steps and how we continue to work with this research piece, but others as well within the Case Management Task Force. So thanks to everybody here, to all the panelists and the presenters, and to IRC as well for putting this together. Take care, everybody.